Hello, this is Kim Jong-dul. Today's subject is the differential diagnosis for Class 2 malocclusion. These four criteria can be used for the differential diagnosis of Class 2 malocclusion: maxillary prognathism and mandibular retrusion, and non-extraction and extraction. Treatment plans should be made in accordance with this classification. And both aesthetic and cephalometric analyses are important for the differential diagnosis of Class 2 malocclusion. In case of maxillary protrusion, the maxilla can be moved posteriorly by headgear or miniscrew. On the other hand, in case of mandibular retrusion, the mandible should be moved forward by functional appliance. According to recent studies of Class 2 malocclusion, there are more cases of mandibular retrusion than maxillary protrusion. What are the cephalometric measurements mainly used for the evaluation of maxillary protrusion and mandibular retrusion? With the FH plane as reference, a perpendicular line is drawn from nasion. Then the relative positions of point A and pogonion from the nasion perpendicular line are assessed. From the NA perpendicular line, the normal position of point A is 0 mm in mixed dentition and 1 mm in adults, and the normal position of point B is -8 to -6 mm retruded in mixed dentition and -2 to 4 mm slightly protruded in adults. There are other measurements as well. Facial plane angle is the angle between the FH plane and nasion pogonion line facial plane. A large value indicates prognathic mandible, and a small value indicates retrusive mandible. The normal value is 86, greater than 90 means prognathic mandible, and less than 82 means retrusive mandible. In addition, AB plane angle can be evaluated. The red line shows where the mandible is in a normal position, but the maxilla point A is protruded. The blue line shows where the mandible is in a normal position, but the maxilla is retruded. From this analysis, A is Class 2 malocclusion and B is Class 3 malocclusion. In cephalometric analysis 1, the distance from point A and pogonion from the NA perpendicular line. 2. The effective maxillary and mandibular length distance of point A and dination from condylion, respectively. And 3. Angle of convexity formed by nasion, point A, and pogonion can be measured. However, an overlooked aspect of cephalometric analysis is that Asians and Caucasians have different skeletal appearances. Asians are brachycephalic while Caucasians are dolichocephalic. Dolichocephalics have long SNA, but brachycephalics have short SNA. Therefore, cephalometric measurements based on Caucasians cannot be entirely applied to Asians. Horizontal and vertical lines passing through subnasal are drawn in profile view taken in the natural head position, and the relative positions of the upper and lower lips and pogonion are assessed. In this patient, the mandible is retruded in profile view. According to cephalometric analysis, facial angle is 85. But the mandible is retruded from the NA perpendicular line. How does this patient look? Facial angle is 85, but from NA perpendicular line. The upper lip is protruded and the lower lip is in a normal position. As you can see, there is a limitation to cephalometric analysis in Asians. What should first be assessed? I look at aesthetics first. Aesthetically, the lips are protrusive in this patient. First assess whether the lower lip is retruded or the upper lip is protruded. Then, the profile and frontal facial appearance are evaluated in edge-to-edge bite. In show bite, retrusive lower lip is observed. In edge-to-edge bite, the anteroposterior relationship is improved by the forward movement of mandible. Of course, the face looks slightly longer from the front, so facial appearance should be assessed from the side first. In show bite, a severe overjet is observed. In edge-to-edge bite, the maxilla is narrower than the mandible. What does it mean if the profile at edge-to-edge bite is unaesthetic? In this case, the lower lip is either normal or retruded, but the upper lip is protruded. Moreover, edge-to-edge bite leads to unaesthetic profile is lower anterior facial height LAFH is long. On the other hand, what does it mean if the profile is improved by the forward movement of mandible? It means that the mandible is retruded and the maxilla is normal. When there is a vertical deficiency, the anterior position of mandible increase LAFH, which in turn improves aesthetics. Then, according to CF, Class 2 malocclusion should be classified as either high-angle type or low-angle type. In high-angle type, the growth pattern is counterclockwise rotation of the mandible. On the other hand, in low-angle type, the mandible is advanced. That is, low-angle type is advantageous for the treatment of Class 2 malocclusion, while high-angle type is disadvantageous. In Class 2 low-angle type, the overruption of upper molars results in the forward rotation of mandible and corresponding forward position of the maxilla. In this case, ODI is high, APDI is low, and CF is high. At edge-to-edge bite, the maxilla is protruded. In general, this skeletal pattern has ODI, APDI, and CF values of about 80, 75, and 155, respectively. Recently, there are more reported cases of mandibular retrusion than maxillary protrusion in Class 2 malocclusion. These cases often accompanies high-angle skeletal pattern with steep POP. On the other hand, many Class 2 cases with maxillary prognathism are low-angle types with flat POP. How are these different types treated? In Class 2 malocclusion with mandibular retrusion, the mandible has to be advanced by flattening steep POP. If the maxilla is prognathic, it has to be moved posteriorly, and POP should be maintained. Aesthetics is assessed first, followed by CF. If the aesthetics is poor with anterior position of the mandible, differentiate whether this is due to maxillary prognathism or long lower anterior facial height. If CF is high, it can be regarded as maxillary prognathism. The growth of the patient should also be evaluated because it can be modified in growing patients. On the other hand, growth cannot be modified in adult patients, so tooth extraction is necessary. If the profile at edge-to-edge bite is protrusive, and the patient is growing and has high CF, it can be regarded that the maxilla is prognathic. How should this case be treated? Headgear or ABP can be used. But how about if the patient is an adult non-growing or CF is low? In these cases, there is a high chance of extraction treatment. In MEAW orthodontics, Cervicalpal headgear is mainly used rather than hypal headgear HPHG. Why is HPHG not used? 1. Intrusion of the upper molars results in steep UOP and subsequent overruption of the lower molars. 2. Posterior discrepancy can be caused. 3. There is no change in skeletal volume. 4. It may be used in a non-extraction treatment, but it is hardly needed in extraction treatment. 1. The use of HPHG results in the intrusion of upper molars, which in turn leads to steep UOP and overruption of the lower molars. Is overruption of the lower molars good or bad for the treatment of Class II malocclusion? It is disadvantageous. In MEAW orthodontics, one of the etiologic factors of Class II malocclusion is overruption of the lower molars. As a result, the advancement of mandible can be restricted. 2. If the upper first molars are distalized by the use of HPHG, how is the eruption of upper second and third molars affected? There will not be sufficient space for the upper second and third molars to erupt. 3. Here is a skeletal pattern with ODI 70A PDI 75 CF 145 high angle type. Can the use of HPHG change this skeletal pattern to ODI 75 APDI 80 CF 155? The skeletal volume cannot be changed. 4. By molar distalization, space can be gained in non-extraction treatment. However, if premolars are extracted, there is no need to use HPHG. Many orthodontists assess mandibular plane angle to decide whether to use HPHG or not, and it is used in case of Class II high angle. But what is evaluated in MEAW orthodontics? CF is assessed, and if CF is smaller than 150 Class II high angle, HPHG can be used, but it is not used in MEAW orthodontics because there is a high change of extraction afterward. When the molars are distalized, there may be sufficient posterior space or not. If there is not enough posterior space, it indicates lack of growth in the posterior region. On the other hand, if there is enough posterior space, it means that the maxilla is prognathic. In normally positioned maxilla, molar distalization increases posterior discrepancy, and as a result the possibility of the extraction of second and third molars increases. We will review this later, but what is the indication of upper second molar extraction? First of all, aesthetics should be acceptable. If the current aesthetics is acceptable, rather than molar distalization by HPHG, it is much easier to extract the upper second molars and move the upper first molars posteriorly into the extraction space. On the other hand, in case of maxillary prognathism, it is possible to move the maxilla posterior, and there will not be any posterior discrepancy. So this is a matter of whether the posterior vertical dimension PVD is sufficient or not. Skeletal patterns with sufficient PVD have high CF. On the other hand, CF is small in patients with insufficient PVD. In this case, the upper second molars can be extracted if aesthetics is acceptable. The profile at edge-to-edge bite is evaluated. If aesthetics is acceptable, then lower anterior crowding should be assessed. If it is severe, extraction treatment should be carried out. If not, non-extraction treatment is possible. In non-extraction treatment, twin block appliance is mainly used in order to advance the retruded mandible and increase vertical dimension. In Class 2 premolar extraction cases, the two main options are only upper premolar extraction of upper first premolar and lower second premolar extraction. Let's think about the premolar extraction guideline. If overjet is larger than 4 mm, evaluate midline deviation. The first premolars are extracted in the upper arch. But if there is an anterior crowding in the lower arch, the amount of retraction is limited. So if there are lower anterior crowding and labioversion of the lower incisors, the lower second premolars should be extracted. If there is no lower anterior crowding, the extraction of only upper premolars can be considered. Whether the canine K is full Class 2 or not is important when only upper premolar extraction is considered. Because Class 1 canine K has to be accomplished after the treatment. What are the characteristics of full Class 2 canine K? These are cases of large overjet or severe anterior crowding, and the upper canyons have to be maximally retracted. Then is it better to extract the first or second premolars? It is better to extract the first premolars in the upper arch. That is, in cases of no lower anterior crowding, large overjet, and full Class 2 canine K, only the upper first premolars can be extracted. If the canine K is not full Class 2, half Class 2 or Class 1, is it better to extract the first or second premolars? If the upper first premolars are extracted, the second premolars, first molars, and second molars all have to be moved forward. It is possible but difficult. In this case, it is better to extract the second premolars and make the canine K Class 1 and molar K full Class 2. Therefore, in cases of no lower anterior crowding and no full Class 2 canine K, only the upper second premolars can be extracted. In case of midline deviation, the upper canine symmetry should be evaluated. If the upper canines are symmetric, the problem is in the lower arch, and there is a high chance of extracting 3 premolars. On the other hand, if the upper canyons are asymmetric, the premolar extraction has to be asymmetric as well in the upper arch. That is, the upper premolars have to be extracted in order to make the upper canyons symmetric. Further details about premolar extraction will be discussed in the lecture about premolar extraction. In Class 2 malocclusion, aesthetics has to be acceptable in order to treat with non-extraction approach. Combination factor can be high or low. If space can be gained, simply MEAW can be used, or a twin block appliance or headgear can be used prior to using MEAW. There is no problem with this treatment. But if aesthetics is poor at edge-to-edge bite, non-extraction treatment can be considered if the patient is growing and has high CF. Since this is a case with maxillary prognathism, cervical headgear and a BP can be used to modify growth by restricting the maxillary forward growth and promoting mandibular forward growth. And then MEAW can be used in finishing stage. In Class 2 extraction treatment, CF is an important factor. If CF is high, the lower arch should be treated with non-extraction approach if possible. That is, only the upper first or second premolars should be considered. But if CF is low, the upper first premolars and lower second premolars can be extracted. Here is a summary for differential diagnosis and treatment of Class 2 malocclusion. In non-extraction treatment of cases with maxillary prognathism, headgear mini screws or twin block can be used, and twin block can be used in cases with mandibular retrusion. In extraction treatment of cases with maxillary prognathism, the upper second molars and lower third molars, or only the upper first or second premolars, can be extracted. If the mandible is retruded, the upper second molars and lower third molars, or the upper first premolars and lower second premolars, can be extracted. Further details of differential diagnosis, treatment, methods, and appliances will be discussed in the Master Course lecture on Class 2 malocclusion. Thank you for watching.